We manage their fear. They are uncertain as to the outcome. We manage their anxiety. More importantly, we manage their pain. We are humans. We can't 100% correctly say this is what's going to happen. So we always tell them there's a good chance he might survive. But there is a chance if he gets these complications, might not. So we don't straight away try and give numbers because every day it changes, it's evolving. We are, as trainers, we have to train them in a balanced way. They are very good with their tests. And this generation asks a lot of questions, which is the right thing to do. If you don't ask questions, you don't learn much.
Hi, and welcome to Island Hustle, and with me, Hifnaz Jifri. This is our very first podcast. Today's guest is someone whose work usually goes unseen, but touches many lives every single day. He's a consultant in anaesthesia in the NHS, working across surgery, ICU, robotic procedures, and end-of-life care. He's come from a very humble background in Sri Lanka, worked really hard, became the first doctor in his family. Please join me in welcoming Dr. Ramali. Thank you, Doctor, for joining us today.
Thank you, Jeffrey, for having me. As you said, my specialty, not many people understand. People are more worried about what happens afterwards or before. What happens inside the theatre or ICU, not many people are. So I'm very happy to be here. Hope I can give something back.
It's our pleasure, and we really hope that people watching this will learn a thing or two. Doctor, first off, I have a question. Who is Dr. Ramali as a person?
I'll start off as a human being. I'm very humble. That's because I'll talk to you about it later, how I come to this stage in my career from my childhood. My specialty is anesthesia and ICU, where the patients are at certain moments, the uncertainty is very, very important, because I have to explain that to them, make them feel relaxed. I can't actually use the word relaxed because they are fearful, they are in pain, and the outcome is uncertain. So my bringing up in childhood, I had the same things because I had a difficult childhood. So it was fearful, uncertain, and the outcome, I didn't know where I will end up. I can reflect that on my patients, and I get into their shoes and try and calm them. So from a humble background, and I've been through my career, I've been through a lot, and I'm here now. It's very difficult sometimes to reflect on my whole career, but the work I've done and the feedback I've got, it makes me very, very rewarding, something like that.
That's great to hear. Doctor, you mentioned you had a hard upbringing, especially when you were younger, and Sri Lanka was at a different stage. Can you talk about your childhood and you growing up?
So you can call village boy in a remote village called Kapuat in Waligama. My father was a school teacher, mother, of course, a housewife. They worked really hard with all difficulties, and he was a teacher. So the village didn't have electricity sometimes, didn't have water. So I still remember going under a street lamp and studying for my exams. I think it's just not me. The whole village, people were finding it difficult. Then I just wanted to do well in school. That was my objective. So I went to the village school for 1 year. Then my father was a government servant. I had to move along the family with them. So he was posted to various areas. Then my mother decided that I should be educated in Colombo. So my aunt used to live in Colombo. So I was sent to Zahira College, Colombo, where my education began. So after that, I went to O-level. I had to go to St. Peter's College to finish my A-level. Medical school is another story.
So how was university life for you, especially with the long curriculum that can get dragged for years, strikes, a lot of pressure that comes from being in university? So talk to us about your life in university in Sri Lanka.
Any teenager's life in university should be memorable. It's the best time in your life because university life is different. But as you rightly said, there were lots of challenges. That era was a difficult era for universities. Usually, the degree should take MBBS 5 years. So we ended up extending it to 7 years. Future was very uncertain, and I was not sure whether I'll be able to finish my degree. So I started applying for universities were closed at short notice. So I had to apply or try to finish my degree quicker. So I applied for other countries and I applied for scholarships. Then things turned out for better. Then after 2 years of not doing anything, we were able to finish the degree in 1991. I graduated. I got my degree certificates.
So, doctor, at any point in that journey of yours, did you ever feel like, I want to give up? This is not working out. This is just not what I planned. This is not what I want for myself. And obviously you didn't give up. And what kept you going?
I didn't have much choice because I've already started in this career. I wanted to do this anyhow. So although it took time, my determination was, because I knew the career will be very good. And those days it didn't strike to me, but now thinking back, I didn't realize the whole world was open when you do this degree. So that's why I ended up, after finishing my degree and doing more work here, I ended up in England. It's always challenging when you have on top of what you are supposed to enjoy in university, when there are other factors which is restricting or making it, and of course don't forget during that time got married, children, so life goes on. But I'm glad I was able to finish it, and there is something called fate also, so
kept you going.
Yeah.
So doctor, you also opened up doors for the entire family. You became the first doctor in your entire family, and since then there have been many doctors coming out of the same family. So what did it feel like to have to obviously open doors and become the first doctor? What did it mean to you personally? What did it mean to your family?
Family, it meant a lot because my parents were proud being the first doctor. My father and mother from a very humble background, and obviously I was looked after by the whole family because they couldn't do it on their own. My uncle, everyone helped in every way, financially and transport, everything. So I should be very grateful to them. So what happened was, obviously, my children, I'm the eldest in the family. So my children were already drawn into doing medicine because they found that specialty rewarding. So my daughter, being the eldest, took up medicine. By that time, we were in United Kingdom, and that opened the doors for all other, my brothers and my daughter's cousins. So we already have 3 more who pursued, but being a female and doing a career was a bit difficult in our culture. But she, alhamdulillah, she went on, and then most of the others have. So she opened the door more than me to the rest of the family.
So let's get into your speciality. Anesthesia is not something that is not like the first picking for a doctor. What made you pick this as a speciality?
I didn't want to be an anesthetist at the beginning. I wanted to be a child specialist. Being a child specialist, you'll be concentrating only on children. So I thought I might lose the adult skill. So I took a 6-month job to do anesthesia. I enjoyed it so much, I couldn't come out of it. So I carried on. At this moment, I still love going to work, love my specialty, and loving it. So I couldn't change. So
it's very interesting. Most people normally think that anesthesia is about putting people to sleep. Obviously, it's not. It's much more than that. So what is anesthesia and what do you actually do in it?
I'm glad you asked that question because most people think that we just put patients to sleep. No, it's much more than that. We manage their fear. They are uncertain as to the outcome, and we manage their anxiety and pain. More importantly, we manage their pain. But after surgery, they wake up. We have to manage their pain as well. So anesthesia actually starts before the surgery, during the surgery, and also after the surgery. The most commonest question patients ask me is, "Doctor, will I wake up?" So I have to manage that bit. I have that uncertainty during my career, so I can be in that situation and explain to the patient.
So you can put yourself in the patient's shoes and get it to his level and kind of him or her and then explain to them.
Everything finishes, they are very grateful because that was their most fearful situation. Having a big surgery, so the patient is anxious, fearful, and someone should be there to walk them. So it goes to show a reassurance. Although it's not prescribed as a medicine, it goes a long way of talking. Communication, building trust, and reassurance will go a long way.
If I may ask a technical question, doctor, what do you, before you give anesthesia to a patient, from a technical point, what do you look for? Is there a calculation that you do based on certain parameters? What's the technical aspect of before you put a patient through?
That again, people think anesthesia is a lot of technical stuff. You have to have a human connection. Robots will come, all these AI will come, but the human connection is the thing which reassures the patient. So it's both. So we have to see the patient. We have to make sure the patient can withstand the surgery. So we do some tests. So that's all done before. And then when we decide the patient is ready for surgery, then it's a different environment. that it becomes technical. Still, we are there physically. We have to be there. And reassurance is the most important.
So you keep saying about reassurance, right? So you probably meet a patient just days before they actually go into surgery, or sometimes you might be called in as a special case to prescribe anesthesia to the patient. So you meet the patient maybe a couple of hours before. How do you connect with the patient? How do you reassure that you're in safe hands?
It's not days before we see this patient. Sometimes it could be half an hour before. So I always tell the patient, you have met the surgeon, you know him, you not met me before, and I'm so and so. A handshake goes a long way, and you just reassure them because you have done your homework. You know about the patient, you know what surgery, all the medications, you done the homework. So I always, the parallel I run is like aircraft. So on the day of the flight, there'll be a crew meeting. So we would have had our team briefing, which we call. I'm like a pilot with a cockpit in front of me. But the human connection, I keep on repeating, should be there. So what I tell to the patient is, I'm going to put a tiny needle into your back of the hand. Next thing you know, someone's going to wake you up to say it's all done. Look after you and make sure you're absolutely fine.
So that pep talk really helps.
And then the patient's next memory is waking up.
Oh.
And then we go and see, and what do you remember last? Oh, doctor, you just told me that you are going to put a needle in here. I'm awake. Surgery is done. It's all done.
So, doctor, one of your areas that you are currently working on is robotic surgery. So I want to understand a few things from it. Firstly, what makes it different from traditional surgery?
So before I start on Jeffrey, I need to go back how it started. It's all started. I just want to tell the audience how far we've come. Good olden days, that did surgery hardly without any anesthesia or pain. I'm talking about 1840s. Then they were pouring some chloroform into maybe a gauze. Patients were asleep and they did the surgery. Then it's come a long way from there. It's the same with the surgeon. It used to be open surgery. They make an incision, cut open wherever the problem is. They take the problematic part and they suture back. That was the original day. They used to know it as a keyhole surgery. Then came the laparoscopic surgery. There's no obvious big cut. They make a few holes and then they do the operation. Surgeon will be doing the surgery with the help of the laparoscopic instruments. Then now the latest is the robotic surgery, where the robot will do the surgery, whereas the surgeon will be on a console. Surgeon has the control. Surgeon will direct or control the arms. The difference is whenever a robot does something, it's clean, more than laparoscopy. Bleeding is minimum and the pain is minimum. So the robot can go to places where the surgeon can't get the hands, but surgeon controls it. Without the surgeon, you can't do this. The anaesthetist is concerned. The same general anesthetic we have to give for all sorts of surgery. I'll talk to you maybe a bit later. The anesthesia has evolved a lot.
So if I may ask a build-on question on that, doctor. So surgeons who come into the medical profession, like yourself, you were not, obviously robotics was not even part of your education system when you came in. So how is it for you to adapt into this technology? Is it difficult? Is it something that you'll have to really go back to your getting coached and coming in? How is this process? For doctors who've been in space for long enough, but this is a completely new technology, they have to adopt because the world is changing. And obviously it's a good technology for medical. So how do you adapt?
More than myself, Adam, is surgeon who needs to adapt.
Okay.
But they'll be doing the surgery. I'll talk about my contribution. So they go onto simulators first, just like airline. So they are on a simulator doing robotic surgery.
Okay.
So they have to do a certain number of simulations. So they can do it on a simulator. Then they will start on the patient. So there are people called proctors. So they are the robotic surgeons who have done a lot and they are teaching now. So they'll do it with a proctor. So there'll be two consoles. So one surgeon will be working and the other side the proctor will be. So proctor also can take control whenever a surgeon needs to be told. So it's a gradual thing and there's a learning curve and there's a certain number of cases, but it's a quick learning curve. The outcome it makes to the difference, or the difference it makes to the outcome of the patient is amazing. Whereas we are concerned, we started off, gas. We come to a technique called total intravenous anesthesia. So you rarely get the anesthetic gases going into the lungs anymore. It's all given through into the blood. So it's called TIVA, total intravenous anesthesia, where most of the time patients wake up with a clear head And there is very less side effects of anesthetics like sickness, almost unheard of. And it's important nowadays, patients are woken up with clear head and with minimum impact because they're all looking at sending patients home quicker after this surgery. So robotic surgery, standard if you do a prostate surgery or a hysterectomy or removing the womb, same evening or the next day patient will be home.
So there's so many pluses.
Good olden days, those patients would have been in hospital for 5-7 days minimum.
So robotic surgery is here to stay.
Oh, definitely. Yes.
So if I may also ask, now you obviously in the NHS, you obviously have, fortunately, new technologies coming to that part of the world much faster. When do you think we could see robotic surgery happening in a commercial scale for people in this part of the world?
It takes a little bit more time, but the surgeons we have are fantastic. They are doing almost the same job as a robotic does with laparoscopically. When the time comes, it will come here because if you see the history, they have been keeping up with technology. Laparoscopy is here now, and most of the surgery is done laparoscopic. So robotics is going to come here, that's for sure.
A specific case, doctor, where doctors thought this is going to be really tough. Maybe we can't do this surgery because it's in a very critical place in the body. But then robotic surgery came in and you were able to do it and the outcome was just beyond expectation. Have you had experience like that?
Definitely. Sometimes our hospital get reference from other hospital. Otherwise, sometimes the patient comes because our surgeons in our hospital are fantastic. So there was one particular patient who was told cannot be operated by another big hospital. So they approached one of our surgeons and that he felt that he can't do it alone. So there were 2 surgeons, did that operations, and patient was very grateful. So it's not only the robot, it's the experience of the surgeon. More cases they do, they can. So always, I have a lot of cases I can recall in that situation or scenario.
Doctor, ICU, critical care, end-of-life care, not very fun spaces to be in, but you spend a lot of time in the ICU. Talk to us about how does that feel? Because you're constantly seeing some of the sickest people who are most of the time, in life and death situations. How do you face that every single day? What does it feel like to be in that environment day in and day out?
It's all about communication. You are not managing just the patient in ICU. Family is important. Communication, trust you build with them and being honest. So the family will tell, the doctor has been very honest. He's told what can be done and what cannot be done. So most of the time, we manage the patient and the family. And as you rightly said, not all patients make through ITU. Then you mentioned about end-of-life care. So nature, always there's an end to life. Sometimes it can happen in the hospital, sometimes it can happen at home. So we try hard. And when it comes to that stage where nature takes over, we can't do anything. So there's another aspect where you can provide we call it a good or a comfortable death to the patient. That's where very important, the end-of-life care. So when the relatives are on board, when they get to know this, what they don't want to their loved ones is not to suffer, not to be in pain, and not to get distressed. And you should see the amount of thank you we get from patients who passed away, saying that you made the final stage of their lives comfortable, stress-free. That's another part. But mind you, Jeffrey, don't forget, there are a lot of patients who get well from ICU and make it. So we are talking only about a small minority of patients.
Let's look at it as, for you as a doctor, as a human being, when you have to deal with life and death situations, when you know there is a chance he can make it from the ICU, but there is also a chance he's not going to. It's critical. How do you mentally prepare yourself? Because that's not easy for you as a human as well. I mean, how do doctors prepare for this?
As I told at the beginning, my journey has been with a lot of uncertainty and reassurance from others. It's all about communication, and we are humans. We can't 100% correctly say this is what's going to happen. So we always tell them there's a good chance he might survive, but there is a chance if he gets these complications, might not. So we don't straight away try and give numbers because every day it changes, it's evolving. So most of the patients respond to treatment, but there's a small group. And family is very important to manage. That's where the problems start. If you don't talk to the family, don't communicate well. So we have family meetings almost every other day or every day. So that's where we have to communicate. If you don't communicate, there'll be issues, complaints, and then problems coming.
So doctor, there's an area that I want to dig in a little bit. So when patients are able to speak openly, near end of life, what are the common regrets they have about their life? Do they share those with you?
That stage is very difficult for us to, at least because we have not been in that situation, we can't get into their shoes. It's a bit different to what happens here, because you can have open conversation with the patient. So we can tell the patient, this is the situation, because it's very important to talk to the patients first.
Yeah.
And we ask the patient whether is it okay for the family members to come in. So be surprised. Sometimes patients get to know before everyone else. I think I've come to this end stage. Patient will know. You'll be surprised when we go and talk to the patient, tell them, I think your chance of survival is minimum. We will do this, but I don't think you are fit enough to have an operation. You won't survive. Oh, doctor, I think I saw what's coming. And I think I don't want to be in pain. I had a good life. Can I have my family with me? And then rest is with the family. And they will talk about good days. So then we take a slightly backward step. And there are teams who are specialized. We call them palliative care. So palliative care kicks in. There are specialist nurses, specialists doing that. So we take a backward step from that time. Sometimes by not doing certain things, you are doing less harm to the patient. Like obvious example is putting someone on a ventilator. If you know the outcome is going to be poor, he doesn't have the capacity. We explain to the patient, said, look, we can't put you in a ventilator because you may not come out of it. And they are grateful.
You mentioned about how important it is to speak to the families involved. Obviously, there are times that this is not going well. It's absolute bad news. It's a matter of days. How do you prepare for that conversation with the family? Because the family is looking up to you, and obviously they want good news. But now you can't give them good news. It's not worked out well. So what do you tell yourself, and how do you go and face the family, and how do you act, or how do you reaction you might get from the family?
So again, Jeffrey, this is all we've been taught. Breaking bad news is something which starts in medical school. So we have been in that situation. So make sure you identify one family member to represent, because you can't talk to each and every family member at different times. So they all come together, but there's one family member which we have recognized. We talk to him with everyone, and he will, there are any doubts, and he will disseminate to the rest of the family. So you don't straight away go and tell them what we are not doing at the moment. Because in a hospital, you are doing certain things. You are giving them oxygen, you are giving them antibiotic and fluids. So you tell what you are doing first before you start off saying that, no, outcome is poor, we are not going to do these things. So you tell the positive things first. We are doing these things. Hopefully, we'll give them a chance. We'll give 48 hours for the antibiotics to work. If that doesn't work, we'll have to look at other things. So this conversation starts well before your real conversation. So in a couple of days' time, you're going to look, we've done these things. I don't think he's improving. We have run out of options. I think nature is taking its course, and they'll be grateful that you've done a lot. And I think now is the time. Keep him comfortable, and I don't think anything you do is going to work. You call futility of care, you call it. It's futile too.
So if you're on the other side, if you're a family that you have somebody in critical care, what are the tips you can give, saying the doctor? Obviously, sometimes doctor can't say it out blunt. He's only going to be trying his best, giving hope, like you rightly said, we are doing these things and this can get better. And then you obviously keep building on that conversation. But you're on the other side. What should you look for in terms of words or things that doctor is saying that you could understand? I think this is it. Because sometimes that helps a lot when you know as from the other side that, okay, you've done your best. The roadway is not looking as much as we would wish for. And this is what the doctor is trying to tell me. If you're on the other side, what would you like them to know, especially when speaking to a doctor?
Okay, so I had to get into the family shoes. So it's again, honesty is important. Not supposed to hide anything. And we don't use any medical jargon, simple terms, because they don't understand. And communicate well, because you are not meeting the patient for the first time. You have been talking to them for a while, so you build the trust. That is very important, because it's not machines and medications we deal with only. So they can do a certain thing and certain amount of work. The trust you build and reassurance and the communication has to go along with machines, modern machines and medicines.
So doctor, you've been in the ICU and end-of-life care for a long time. Has there been an emotional, special case that has touched you or stayed with you for longest time where, it was too deep, too emotional? Is there any particular instance that you would like to talk about?
The whole public was working from home. We had to go to work during the COVID pandemic in intensive care unit. So I've seen one whole family being wiped out in ICU. And also, sometimes we put ourselves in, you could be that patient on the ventilator in a week's time, myself. So because we are dealing with them, we have to intubate them. So we go closest to their mouth, pass a tube and put them on a ventilator. We had all our PPEs. So it difficult, emotional, to thinking of your family. Morning you are going to work, evening the family expects you to come home. But if you come with sickness, so that's the nature of the work we do. But we were lucky, we were given all protection. Yeah, we did our maximum.
Have you ever seen what you would personally call a medical miracle, doctor? Something that everybody who saw this patient probably thought, no chance. But, magically things worked out and he walked out of ICU as never expected. Have you ever seen medical miracles?
I had two in my memory, which we all had given hope. So one was, I think, when I said give up hope, we said we won't do anything further. We'll put the patient in ICU. And if the patient gets better, that's fine. There was a lady who bled about 40 liters during the surgery. And we gave about 120 units of blood and blood product. And we said we are not going to do anything more. We just put the patient in. And next day, I was not working. I was up all night. And my colleague from ICU is calling me. By the way, your patient last night started to respond. She started to wake up. That's number one. So that's the time I knew we just need to keep on doing things until there's a SOB. And there was another young girl who was an athlete during the operation, aspirated. So things went in the wrong way, lungs. And then we couldn't manage the oxygen in our own hospital. So we had to transfer to another specialized unit where they are put on a temporary bypass. We've heard of cardiac bypass during heart surgery. This is temporary bypass where you rest the lung and do it artificially, the oxygen. And she survived and she's back. She was back doing athletics. I mean, those are the two things which
you consider medical miracle.
Miracles. But we kept going. Yeah, we didn't give up.
Doctor, so talk to us about leadership lessons you have learned through practicing medicine and being a medical professional.
That's another important skill we look for when students go into medical school. So leadership is, we always drive into the students' curriculum. Doctors, most of the doctors are good leaders. You are being any specialty, it's not a single person's job. It's teamwork. So everyone has a team. So leadership is having your briefing, meetings, and delegating stuff to your team. And the most important thing is at the end of it, you get a feedback what we could have done better. So say example is in a operating theater, we do a surgery. After the day finishes, say we had 3 surgeries, so we have to do what is known as a debrief. So the team leader will do that. So what could have gone better today? What went well today? Anyone has any concern? So they will ask each team member anything to contribute. So a good leader will be the one who manages the team well. So it's all about teamwork. And leadership is always taught in medical school. And you are practicing it throughout your career. So it's very important skill to have.
Good to know, Doctor. You touched on the basics of leadership. So every doctor should have some briefing to obviously monitoring, then obviously delegating, then debriefing, and obviously learning from it and improving. So which makes perfect sense. Doctor, on a personal level, obviously as a doctor, as a human being, everybody goes through stress, regardless of whichever line of work you might be in. Personally, because especially in your line of work where you kind of come across a lot of stressful situations and you have a very short time to act on it, is there anything that you practice to control your stress or get better at responding to it rather than to reacting to it?
I mean, personally, if you ask me, my way of doing things is I don't take work home. So work finishes in the hospital and go home and I relax, recharge, sports, running, spending time with family. Now I have even a better way of relaxing with grandkids. So I think it's because of our speciality. We finish our work, go home, completely not worried about what is happening because the patients will be looked after by the team or the surgeon. We finished. And next tomorrow is another new day for us. I'm preparing. And I think it's easier said than done for someone to say, how do you manage stress? Because there's some individuality also. So certain people will do different way. But in my case, that's how I relax.
So doctor, let's go from your expertise into your journey. You moved from Sri Lanka to NHS. Talk to us about that initial culture shock, the transition. How did it feel like?
Individually, it's the same. Different people, the way they communicate, it's nothing wrong. Here, everything is done very well. But there also, it's the system. So NHS itself, they say the culture. So before you go there, you have to learn how the NHS works. Without that, it's difficult. So their system is different.
So when you say system difference, what are the biggest differences you saw from moving from here when you moved there to maybe the 2 or 3 differences that struck you like, oh my God.
Difference is communication. You have to communicate more there with the patient, talking to the patient, spending more time. And here it's done in about 2 or 3 times more there. So more time in communication. And also you have done a lot of things here and you are very good at them, but there it may be done in a slightly different way. So my biggest challenge was first 2 months, pretend as if I don't know much because I didn't want to do anything differently too. So I pretended as if I didn't. And when I got to know, then they got to know, oh, he's done some work in Sri Lanka. I mean, I've got fantastic training here. When I say I had to pretend I had done more work before I went there than there. But I had to go slow.
It's interesting you said that, doctor. It reminds me of something somebody taught me when I was much younger. And that said, if even, and not in terms of being a doctor, but in terms of being a professional, you might go to an entity, a new company, and the very example he used at that point was, you might be really good at Excel, Microsoft Excel, but they might teach you saying things that they might start teaching you Excel all over again there. And when they do that, his message was, act as if you don't know. Because you might know 99 things they will tell you, they might not know one thing that which you didn't know. So learn. So that should be, especially when you're younger, you have to really pay attention and try and learn from whoever you can, because that's the only thing that's going to make a difference. So it's very interesting that you actually mentioned that.
We still learn exact things every day.
That's great, doctor. That's great to hear from you. So when it comes to the NHS, what do you think NHS does exceptionally well compared to anywhere in the world?
I mean, NHS history is very important. 1947, the government made it free for at the point of care. So it's a free service. So patients can have access. We have a system which is like here, the hospital system here. So it's GP-led service. General practitioners see the patients first, and then they are treated by the general practitioner. If they need to be transferred or referred to a specialist hospital, they refer. So the most important thing is it's divided into primary and tertiary healthcare. Primary is the general practitioner, tertiary or secondary and tertiary are the specialist hospitals. It's free at the point of delivery. That is the biggest thing. Before that, it wasn't. Anyone have access to NHS at any time, and at the point of delivery, it's completely free.
So what's something that public often misunderstand about healthcare workers?
My specialty, I don't know, I don't see many patients outside my specialty. Miscommunication is, or misunderstanding is, someone has a surgery. They are very fearful of anesthetic. I've told this before. I'm not sure they wake up. And the number 2 is someone in ICU, they think the patient won't survive. And it's very difficult once they go into ICU. So if they're put in a ventilator in ICU, then that's my specialty. But
so they feel when you go into a ventilator, that's it. Yeah. It's not going to.
What I can reassure is medicine has advanced so much now. So it's very safe. I'm talking about anesthetics. To have an anesthetics now. Very safe. And intensive care, obviously, because of communication, we can give a better understanding.
Doctor, I'm going to jump into something in terms of vaccination. That's something that even I as a parent have asked myself, is it really necessary? So children today, they follow a strict vaccination schedule, if I may say. From the time they're born till about 12 years. vaccination after vaccination. And as a parent, I always ask, do you really need this? I don't know whether it's something that because medicine advanced so much that now they've picked up a lot of things that you need to go through this for safety, or what is it, doctor? Why are children put through so many vaccinations from the time they're born till about 10 years?
So first thing I want to say, Jeffrey, is it's not my speciality. Whatever I say will be limited with limited knowledge.
Take it with a touch of salt.
No, not exactly. So I can't say anything which I'm not sure here. But the important thing is, don't forget, I've not been only a doctor, I've been a parent as well.
And grandparents.
So vaccination didn't start just overnight. Right? If you go into history, polio epidemic. How did the polio get eradicated? They didn't have a vaccine. There would have been still polio cases. And same for other illnesses. Tetanus. If you get tetanus, that is very difficult. You may not survive. Other important thing is rabies. But you are talking about childhood vaccination. So polio is one of them. So this vaccine has been researched and tested. They go through years of clinical trials. But there is nothing in this world or medicine which is risk-free. You take paracetamol, it's got side effects. So it's balancing the risks and the benefits. So poor children, they can't make decisions. So a parent is making a decision for the child. Later on, it will have an impact when they are adult. So one of the children, say, got whooping cough or measles and ended up being deaf because that can cause deafness. So then the child can ask that, why didn't you not give me the vaccine? How did I end up getting whooping cough? Now I can't hear. So it's difficult for parents. So only way you can is ask a specialist doctor about that. Nowadays the issue is, that's saying I don't want to any Asian countries, I'm not saying Sri Lanka. Every other person is a doctor, you come across.
Yeah, so true.
You have to ask the right person and the right specialty, and you have to trust them. It's asking the right people, and everything will have some side effect, balancing the risk.
Thank you, doctor, for that. I've known you for long enough, and I've seen your journey, how successful you become over the years. One thing I really admire about you is how humble you are. You're very down to earth, still approachable, very giving and sharing. How is that possible? Because you see a lot of people, while there are many good ones, there are so many cases you see where success hits your head and then you become a completely different person. You've been true to your roots. You've still been that humble person. Talk to us about what keeps you grounded.
See, these parents' genes. My father was like that. My mother was like that. And I had a difficult... When I say difficult, it's not where we didn't have enough facility. That's what I'm trying to say. Didn't go through very severe hardship. I didn't reflect badly on my parents. But with limited facilities. But they did very well to bring me into this state. So the roots I can't forget. And that's what, as you rightly said, anyone want to talk to me at any time. I'm accessible. So that's one way you can give things back. This humbleness, I think I got from my parents, my father and my mother. And I was helped by a lot of my family members. So I knew the contribution and I went through this. If they didn't help me, I wouldn't have been in this situation. When I say being a doctor.
It's good to hear, because that's not a common thing, doctor. I mean, that's not something that you can easily see. So very, it's a skill or it's a quality that is not very common. So I'm glad you talked about it, and obviously, yes, I think you're right. Parents play a huge part. I think what's most important is you remembering where you came from and how much you can give back, because at the end of the day, that's what really matters. Doctor, switching into medicine and doctors who are coming into medicine now, right? So you obviously seen doctors who are older than you who came and then obviously people who came after you, then you got the millennials and now you got the Gen Zs. How is it working with Gen Z doctors? Is it a challenge, or are they bringing new perspective? What's your take on this new generation getting into medicine? Who's the generation who's probably seen technology far more than any of us have, and where technology was accessible? What is your experience working with them?
The path that you come through is long, and we've been through these changes in a different way. Like when we started, we had to wait about 5 minutes. You still remember the dial tone for internet?
Oh, yes.
If we didn't embrace that, we wouldn't have been here. So they are just starting their training. So that's what we are as trainers. We have to train them in a balanced way. So they are very good with their tests. And this generation asks a lot of questions, which is the right thing to do. Because if you don't ask questions, you don't learn much. When we were students, we were not asking enough questions. The lecturer will point at us, and here the Gen Z, that be even before you finish the lecture or finish the teaching session, they'll be asking questions, and even during that. So we have to mix the advancement in technology with the old school, whatever teaching method, so the practice. But you have to embrace it. You have to.
Yeah. So, Doctor, I'm mostly talking about the personality of Gen Zs, right? So, something that's commonly told across in different forums is that they get easily stressed, or they use the word "I'm traumatized" quite often because of the workload and what's going on. How do you see that happening in your industry, and how do you manage that?
So that's very important point you mentioned, because there is a big area called burnout, and it's our responsibility, not only for Gen Z, all the doctors. So there are some regulations. So none of us can work long hours. If you work a certain amount of long hours, you have to have a rest. And it's more than that. There are mentors they can talk to. There are a lot of people, lot of support given.
Okay.
So they get stressed. Absolutely, you are right. But they have to be guided. And it's our responsibility. So burnout is a big area which we are focusing, and they have enough help. And they have a lot of people to talk to. And there's even it depends on each hospital. Our hospital will have a out of hours phone call service where that junior doctor, your doctor you mentioned, can talk to a very senior person. We have picked up 7 doctors to be on call just for that, seniors, and we are on the phone. 7, not.
So there's a service to take care of them.
Not working hours, I'm talking about
after work hours. So Dr. I think we come to the last part of our conversation. So what message do you have for any young person thinking of pursuing medicine or getting into medical college? What do you like to tell them?
I think everyone tells it's a noble profession, you are doing humanity, service, all those things. That's fine. Medicine is a specialty. It's so opened up so much, and there are lots of specialty. Basically, when my children decided to, I never forced anyone in my family. They said the whole world is open to you. So don't think locally. Lot of specialties you can choose. Okay, you know, medicine, law, big specialty. Or you don't need to be with patient. You can do radiology, or that has got some patient contact. Histopathology. So like that. Or if you are really liking surgeon, orthopedic surgeon. So there are lots of specialties by open, or community medicine. You can get into one of those, whatever you like. So the whole world is open. It's a fantastic specialty, and it's very rewarding. And every day I look forward to going to work. Most important thing is, when you come back home, you then reflect and enjoy the moments in your work at that, how the patients felt, how grateful they were. So that cannot be matched.
Yeah. So if you're getting to medicine, the world is your playground, and there's a lot to be looking forward to. A lot of areas have advanced. And like Doctor said, when you get back home, you have a lot to be reflecting and being happy about, because you obviously changed lives. Doctor, last question before we close on. What do you like to tell the general public about health and life?
Yeah, so the general public, the message, if this is the only message people can remember, people talk about lifestyle changes. So I'm wearing a different hat. I'm not going to be an anaesthetist in ICU. If all the patients were good and they were well, we don't have any work to do, because they're all healthy people. Yeah. So lifestyle changes is very important. Small, consistent changes are much more effective than short-term, high-impact changes, which is not good. So lifestyle changes is very important. Prevention is better than cure. The good old saying, the community diseases like diabetes, heart diseases, most of those diseases, even cancers, lifestyle changes is the message I want to give. Smoking, quit smoking. If you're not doing enough workout, instead of walking, do that. Dietary, very, very careful. And prevention. So screening is very important. If you are worried about something, if you have family history of something, just get to a doctor and get yourself screened to prevent those things happening. Because certain can be taken from family or from generation to generation. That will be my take-home message, which has nothing to do with anesthesia, nothing to do with ICU.
Thank you, doctor. So with that, we've come to the end of this session, and I would like to thank all of you for watching, and thank you very much, doctor, for joining Island Hustle on our first podcast. And I hope we've done justice to the ones watching. And I really hope to have you again sometime when you're on holidays in Sri Lanka next time. And I wish you all the very best and have a safe flight, doctor.
Thank you, Jeffrey. It was very nice and enjoyable. And thank you again for giving me this opportunity. Thank you very much.
Pleasure is all mine, doctor.